Welcome to Pregnancy, Birth and Beyond, where stories, science, traditions and new ideas meet. Our podcast is coming to you from Bundjalung country, also known as the Northern Rivers in New South Wales, Australia. We acknowledge the traditional owners of this land, the Arakwal people, the Minjingubil people and the Widjabul people of the Bundjalung Nation, and the many other tribes that frequented this area. I pay my respects to elders past and present, and those emerging. As individuals, a team, and organization, we acknowledge the traditional custodians whose cultures and customs have nurtured and continue to nurture these lands for over 65,000 years, and upon which we now work and live. We acknowledge that sovereignty was never ceded, and recognition of culture, connection to land and waters, and sovereignty of all Aboriginal and Torres Strait Islander peoples across Australia is a matter of current and vital importance. I'm Analia Tia. Thank you for joining us today.
And that means in 2021, the biggest risk factor for a mother anywhere in the world to get a C-section is not her personal risks or her personal preferences, but which hospital she goes to.
That's Dr Neel Shah, Assistant Professor of Obstetrics, Gynaecology and Reproductive Biology at Harvard Medical School and Director of the Delivery Decisions Initiative at Harvard Adriani Labs. We caught up a couple of weeks ago to discuss equitable and safe maternity healthcare, how C-sections are the most commonly performed surgery, and why it's so important to reduce the very high rates of major surgery in childbirth. For more information about this episode, please check the show note links or head to our website, pbbmedia.org. So welcome, Dr. Neel Shah. Thank you so much for joining us on the Pregnancy, Birth and Beyond show. We're honored and delighted to have you.
Thank you so much for having me.
So where are you chiming in from today?
I am in Boston, Massachusetts, where it is late evening. I think it's first thing in the morning for you.
Yeah, it's true. On a Saturday morning, so late in the evening on a Friday night. Is that right?
That's right. You're living in my future.
So true. Thanks for joining us. I'm so excited actually about this interview because the work that you're doing seems to be so important, and I don't see many other practitioners and healthcare providers and researchers working in this specific arena. One of the things I'd love to focus on today is the work you're doing to reduce the C-section rate. And it looks so exciting. What can you tell us a little bit of an overview about this project before we get into the nitty-gritty of it?
Yeah, absolutely. So across the entire world, the most common major surgery that we perform on human beings is C-sections. The most common healthcare service that people seek out is childbirth. And the way that human beings come into the world has changed radically from the last generation to the current one. In the United States, C-sections have become 500% more common. And it's designed to be a life-saving surgery. It's designed to be a rescue. But even though there's been a 500% increase in the use of this major abdominal surgery, full-term infants, meaning babies that are born on time, they are 0% better off. And an American mother today is 50% more likely to die in childbirth than her own mother was. And in fact, she's 3 to 4 times more likely to die if she's Black than if she's white. I think that's what really started the journey, is to try to understand how that could possibly be true. How could we be doing so much more surgery to people that's designed to save them, and not only not being effective, but actually in some cases making people worse off?
Wow, what a strong and very sobering set of statistics just right there. And I didn't know that C-section, the cesarean section, is one of the most common surgeries that we perform on human beings. That's an incredible piece of information. So what do you think are the reasons for the increasing rates of C-sections?
Most fundamentally, it's a failure to value childbirth and people's experiences during childbirth. Life only has two certainties, which is the beginning and the end. And as a result, it's really easy to take it for granted. It turns out people will have babies whether they have safe and dignified ways of doing it or not. And whether it's in New York City, where 1 in 3 people will get this major abdominal surgery to give birth, and 1 in 10 of their babies will go to the ICU, or in sub-Saharan Africa, where routinely mothers will die giving birth. It's treated as normal. The status quo is just sort of treated as normal. It's a really odd phenomenon. There's something about the universality of childbirth that makes us less empathetic to each other. The fact that everybody does it, with C-sections in particular, is just everybody knows somebody who's had one and they seem like they're fine. So we forget that it's a major surgery that has real consequences.
So I guess a lot of normalization is happening, and also a lack of a deeper understanding for the impacts as well from everyone that's involved. What drew you specifically to this particular area in healthcare?
Before I became an obstetrician, I had an interest in the healthcare system more broadly. I was finishing school just as President Obama was elected, and a lot of my professors ended up joining his team and working with him on the biggest healthcare legislation in my lifetime, which we call Obamacare, but is also known as the Affordable Care Act. And that gave me insight into the fact that childbirth is exceptional in ways that are good and not good within the healthcare system. It is the most commonly utilized healthcare service, as I mentioned. C-sections are the most common surgery, but the list of superlatives just goes on and on. It turns out not only has C-section rates gone up, but it turns out that at the hospital level, C-section rates vary tremendously and more than any other healthcare service. In the US, at one hospital, the C-section rate is 7%, and at another hospital, the C-section rate is 70%. And you see the same kind of variation across Australia and across most countries in the world, actually. And when you try to explain how could there possibly be tenfold variation in the use of this surgery for such a common and fundamental healthcare service, and you say, well, maybe in some places, the people that they're taking care of need more surgery, maybe they're higher risk, and you try to account for that by only looking at the lowest risk mothers, you don't see tenfold variation, you see 15-fold variation. And there's no other healthcare service where after you account for risk, you see more variation, not less. And that means in 2021, the biggest risk factor for a mother anywhere in the world to get a C-section is not her personal risks or her personal preferences, but which hospital she goes to.
Wow. I mean, from the perspective of us here at Pregnancy, Birth and Beyond, and also myself working as a consumer representative, which is somebody who represents people who access healthcare services here in Australia, that's something I'm aware of. And because I speak to so many hundreds of women over the last few years in healthcare providers, but to hear it being said so clearly from an expert in this field is such a powerful statement to make, because it's oftentimes something that's not expressed so clearly. And I wonder why we're not hearing more. You may not know the answer to this, but are you hearing more of this around you, or are you kind of spearheading a movement? What are you seeing on your end?
I'm seeing progress. I think that the statistics I rattled off are all shocking, but they have been trends that have been evolving for a long time. These aren't recent phenomenon. Like the fact that an American today is 50% more likely to die in childbirth than her own mother, that's not a recent phenomenon. That's not a statistical blip. That is a trend that's been ongoing for 25 years. And what has started to change, well, it started off with, I think, honestly, journalists documenting what was happening and telling the stories, because our government wasn't tracking it. There was no system that was tracking it in my country or even across the world in effective ways that really gave us insight into who was being most impacted and why. And it took journalists going to Facebook and local newspaper obituaries to tell the stories of these women, of these moms who are dying. I think the other thing that is a challenge across the world is that mothers are expected to put their own well-being last in order to put their families first. So even while on one hand, mothers can be revered and there can be a lot of gratitude for our own moms, thinking of moms collectively and truly valuing them independently as people, and not treating them just as vessels for pregnancies is something that seems to be challenging. I mean, in my own country, moms are very good at advocating for every progressive cause except for their own well-being. There's moms against drunk driving, there's moms against guns, but there's no moms for moms. And that is a fundamental difference from, say, like cancer, where if there's a meeting about cancer, you can push a button and 1,000 cancer survivors will show up. But for maternal health, it just doesn't work that way. Moms will show up for their children, they'll show up for other progressive causes, but the expectation that it's okay for moms to advocate for their own well-being is just a fundamental paradigm shift that needs to happen, but hasn't fully happened yet.
Sorry, I'm a little bit tearing up because it's such a powerful acknowledgement and recognition that we're so needing as mothers to hear from our care providers. But also, like you say, we do need to see more mothers showing up for mothers and mums for mum. And historically, like you're saying, that the great expectations that we have of mothers makes it very difficult for mothers to recognize to begin with that they can advocate for themselves and that they are of value within the bigger picture when it comes to motherhood and parenting. It's something that's really hard to get through, say, to younger women who've never had children before. And even I find with feminists, they often neglect this most innate aspect, maybe not of all women, but of many, many, many women. So many, many women will become mothers and will give birth. And here in Australia, the statistics are very clear. The people who do the overwhelming majority of the unpaid work are women, which means that those are the women that are showing up to take care of our elderly, of our children. They show up for lots of the volunteer work. And whenever something needs to get done, there'll be lots of women showing up to help make that happen. Not to say that men are not coming, but it's absolutely the overwhelming majority of that unpaid work is done by women, which means that they're showing up for that kind of need within the community. But it's so true that they often neglect to show up for themselves. And it's a powerful statement to make from our healthcare providers and from people that are in it to really support women. And I'm loving hearing that. So I really appreciate it. And thank you for that.
Sure, of course. I mean, and I want to be clear too, I don't want to put the burden of responsibility on women or mothers entirely. It's not the job of mothers to save themselves and save the rest of us at the same time. That's ridiculous. I think really the point that I want to make is that our expectations are too low. Like, people have goals in giving birth other than emerging from the process unscathed. So if we only track survival, or if we make the goal of the system not death, we're aiming too low. We need to have a system of supporting people during birth so that, it's a safe experience, of course, but it's also supportive and empowering, and that mothers themselves can demand that. Like, that if you leave the hospital and your baby is alive and has the correct number of fingers and toes, like, that's good, but that's not all you deserve. Like, you don't have to be happy just because of that.
Yeah, it's a great area that we've been looking into for many years, actually, this specific statement that is often used to approve everything that goes on in maternity care. Well, as long as you have a healthy baby, or why are you complaining your baby is healthy and you're both alive? And those statements that are so easily used by not just care providers and the system, but also by community. When a mother comes to people and might say something like, I'm depressed, or I'm feeling unwell, or I have these terrible pains in my body because of interventions that have been incurred through childbirth, people will use those statements to brush away a very deep and impactful psychological and physiological impacts of childbirth that not enough people are recognizing and honoring. And so what are your strategies to improve maternity healthcare in general? And then I'd love to hear more about reducing the C-section rates.
Well, I think that the first step is making sure we're solving the right problem. And I think that people often jump to the solution without really thinking through what the problem really is. In this case, we've treated people's experience of care as a secondary luxury that you get to after you've made people safe. And the truth is, we got that backwards. The way that you make people safe is attending to their lived and embodied experience. In the United States, when you look at every story of maternal mortality or an avoidable case of an injury during childbirth, what's killing people is not a hemorrhage. People survive severe hemorrhages and they don't survive more moderate hemorrhages. The difference when you do a root cause analysis in almost every case is a failure to really listen and hear people when they express concerns, whether they're Serena Williams or anybody else. When people are in the vulnerable position of being in labor and giving birth, and particularly if they're from a historically marginalized and oppressed group, if they're Native, if they're Black, if they're an immigrant, there's really good data that our healthcare system is slower to respond, and that failure to listen is deadly. So it starts with just correcting the false idea that people's experience is a luxury that you get to after you made them safe. Paying attention to people's experiences is the way that we make them safe. And I think the other really important framing is that given all of the unpaid labor and everything else that you mentioned that is attached to motherhood, all the suffering that's not only from undertreated illness, but also from just economic disempowerment, social isolation, all those things, the well-being of mothers is the bellwether for the well-being of all of us. So if mothers are unwell, society is unwell. And the evidence for that is the fact that every injustice in our society shows up in the health outcomes of mothers. It's not just that racism and maternal health interact. It's that one of the leading indicators that structural racism is a clear and present danger that kills people is disparities in maternal health between Black women and white women. Right after incarceration rates, it's like the number one indicator. So I think, long story short, it's making sure we're solving the right problem.
This is Pregnancy, Birth and Beyond, and you're listening to an interview with Dr. Neel Shah, Assistant Professor of Obstetrics, Gynaecology and Reproductive Biology at Harvard Medical School and Director of the Delivery Decisions Initiative at Harvard's Adriani Labs. For more information about this interview, head to pbbmedia.org or check the show notes for podcast links. In terms of the C-section rates, as you mentioned, that's the most common surgery that is provided. Can you actually repeat that again? Is C-section actually the most common surgery?
It's the most common surgery. So the WHO has 3 surgeries that they use to measure the robustness of a healthcare system. And one is fixing a long bone fracture, like an arm or a leg. Mm-hmm. Another is a surgery called an exploratory laparotomy, but that's basically like when you have to operate on somebody's abdomen to like take out an appendix or something. And the third is a C-section. And of those 3 surgeries, the C-section is the only one that as soon as you install the capacity to do it, the equipment, the trained clinicians, you massively overuse it. This is true in every country, particularly in transitioning countries. But the statistic is that the most common surgery performed on human beings, the most common major surgery is the C-section.
Wow. So tell us a bit about the Teen Birth Project, which is specifically designed, as far as I understand it, to help reduce the C-section rate there in the United States.
Sure. Yeah. it's designed to address the C-section problem and so much more because, and again, it comes back to this theme of solving the right problem. Every other quality improvement target, the target is 0. So if it's infection rates or mortality rates, you're trying to get to 0. C-section rates, the target is not 0 because C-sections truly do save lives. And what's complicated is we don't know what the target is. And C-section rates mean different things depending on whether it's a countrywide rate or a hospital-wide rate or a physician-level rate. But at the hospital level, what the C-section rate tells you is something about the quality of labor management, because not every hospital is trying to decrease their C-section rate, but every single hospital, for every single person in labor, they're trying to get them an uncomplicated, normal vaginal delivery. So, if your C-section rate is high, it means that you're not supporting people in labor. That's just a fact. What team birth is about is the recognition that first, childbirth is a team sport. It always has been for Homo sapiens. And 80 to 90% of errors, injuries, failures during childbirth are failures of communication and teamwork. And the team that comes together to take care of a person in labor for every person, every time, everywhere in the world comes together randomly, because you can't predict when the person is going to go into labor and they're a member of the team, and they can't predict who's going to be in the hospital to take care of them. And yet you have to become a high-performing team for the first time, for the most important moment of your lives. So team birth was basically an idea to try to solve that problem.
So is team birth essentially making people who are on the ground, who happen to be rostered on at that time, better at working together as a team? Or are you also aiming for providing a different model of care where smaller teams take care of a single person accessing healthcare services? Because what we see here in Australia and essentially in research, in leading research from around the world, is that when maternity care is provided in a continuity of care model, so the same care provider or small team of care providers taking care of the single person accessing the healthcare for the duration of their pregnancy, the childbirth, so the labor and birth itself, and postnatally for the first 6 weeks, everyone fares so much better. So outcomes are better, experiences are better, also for healthcare providers as well. So is team birth working towards creating teams that are providing continuity of care, or is it about making sure that anyone who's available on the day can come together quickly as a team and work to support that person who's accessing the care?
By the way, my toddlers are just waking up, so they may end up becoming part of this podcast.
Wonderful.
But they, there are many things that plague the functioning of our healthcare systems, and continuity is one of them. Like you're saying, making sure that you've got a person who really knows you longitudinally over the course of the care that you need. And another is coordination. It's really the latter that team birth is focused on. It's the idea that really during the episode of care where you are in labor and giving birth, every person in the room has information. The midwife, the obstetrician, the nurse, the person giving birth, her partner. When we're making important decisions, the information that lives in everybody's brain, like you need a way of reliably sharing it. So it's literally this simple. It turns out there's a dry erase whiteboard in every inpatient room, at least in the United States. And it's primarily used in our country, at least, for nurses to talk to themselves. And, they're highly variable in information. So all we did is we made a big one that everyone in the room can see and read from anywhere in the room. And we simplified it so everybody can understand what's on it. We defined what are the things that a clinical team and a person giving birth should talk about during every labor assessment, every time, everywhere. And we structured the board to capture those things and make everybody accountable. So it has 4 quadrants, and in one quadrant, you write down the name of every member of the team, starting with the person giving birth. And that's because every high-performing team needs role clarity, and everybody needs permission and opportunity to speak. It's about psychological safety. It's about saying, you as the person giving birth are at the center of the team. Then there's a place where you write down the things that only the mom can tell you, kind of like a birth plan, but you can change it as things go rather than having a fixed piece of paper. Then there's a place where you write down, what the plan of care is. And then there's a place where you write down when the next time the team is going to get back together again and talk. And it doesn't have to be a specific time. It can be, when you think you might want an epidural or when you think you might want to push. You can write anything you want. We don't prescribe it. But that's so that mothers don't feel like passengers on a plane that's being held on the tarmac of the runway without the pilot explaining what's happening, which is how almost every mother in the world feels. They have no idea what's happening next because nobody tells them. They don't. So that's all it is. And it turns out that very simple innovation, if you can call it that, is transformative. We ran a clinical trial that involved tens of thousands of families and hundreds of clinicians across the United States and saw that it made everything better, Annalie. Like it made it more likely that the person giving birth had the role that they wanted in their own care. It made it more likely that they were understanding what was happening to them. It made it more likely that they felt like their input made a difference. And in some cases, it decreased C-section rates, it decreased unexpected newborn complications, and it decreased severe maternal morbidity.
Wow, that's amazing. It's such a simple and also obvious, I guess, to those who who are really looking into what's creating the situation to be as it is. But it seems such an obvious, a simple tool, and it's such a wonderful one where you can really bring together in a scenario, in a situation where you can't or cannot provide continuity of carer, as so to speak, that the team would be more efficient and more together and more connected and more responsive as well to the person that they're taking care of and to each other, being able to have this kind of communication board or a space to work together from. Are people now taking that on and implementing that? What's the next step after the research?
Well, we did the research to show that in community hospitals, people can do it, that it has benefit and value, but also it's feasible for clinicians to do it and that they don't hate it. It's really important to recognize that in life, just like in healthcare, we often face a dichotomous choice between doing the right thing and doing the easy thing. And so often they don't line up. And whenever we're trying to make things better, especially in healthcare, we actually make it harder for clinicians to do the right thing. So we really designed this to be that simple and show that clinicians could not only be willing to adopt it, that they would be enthusiastic, that they would appreciate feeling more aligned with the person that they're caring for, and that even it wouldn't take extra time, that they could recover efficiency through it. So that was the study objective, and we did that. And the goal is in the next 3 years to make this a standard of care that everybody benefits from. My, model is this thing that's called the surgical safety checklist, where every surgeon, before they pick up a scalpel, has to run a checklist. It seems ridiculously simple, and it's the equivalent of what a pilot has to do before they hit the throttle. Every pilot has to run a checklist. It turns out this checklist has been shown to reduce mortality from surgery for every surgery on every continent. And after the smallpox vaccine, the WHO thinks it's the most impactful thing they've ever done. And I see teen birth as having the potential to be the equivalent. So the goal is in the next 3 years to make it that kind of standard of care. And to do that, we're trying to demonstrate that it can work in the toughest places. For example, we're working in a city in the United States called Tulsa, Oklahoma. It's right in the middle of the United States. And it's a city within a state that has some of the worst maternal health outcomes in the country and the widest racial disparities. In fact, the hospital that we're working at, it's in the same neighborhood where there was an event called the Greenwood Massacre that most of the world doesn't know about, but will in the next year because they're coming up on the 100th anniversary of the event. And they're digging up the mass graves literally as we speak, where an entire neighborhood of a Black community was burned to the ground. And events like that, they seem like they're in the distant past, but the legacy of events like that carry on in the opportunities that people have and in their health. It turns out the people that live in that neighborhood or their hospital is the same hospital that has the worst outcomes and the least resources. So we're going there and we're trying to show that team birth can make a difference there. And if it can make a difference in Tulsa, Oklahoma, it can make a difference everywhere. Like nobody else has any excuse. So that's the strategy.
Wow, that sounds so powerful and so important as well, to bring extra care and simple ways for community and care providers to work better together to improve outcomes. It's so important. I totally hear you on making things easy and something that clinicians and care providers don't hate, or doesn't make their life even so much harder because they don't have the structural elements to help support them to make great change. The system is so cumbersome and so difficult to change that these kind of strategies that almost kind of override what the system does in some ways, which is hold people down from being able to do better. It's such a wonderful tool. I can totally see how it would be so supportive in so many different settings. And it's really exciting. It's such a wonderful project that you're working on. And I'm really looking forward to hear how it works out in Tulsa, because that sounds, it's big. It's big, all that's happening in the world and how things carry through, and we kind of think, oh, that things happen, but it doesn't. It's a little bit like birth, isn't it? So the impacts of childbirth, I often speak to elderly women, to women in their 70s and 80s, sometimes in their 90s. And when we talk about their childbirth experiences, they'll tear up. They'll tear up either in joy or from trauma that they've experienced that was never fully digested and that still lives within them because it was such a powerful experience. And so finding ways to address that and acknowledge that seem to be such important parts of our humanity as well, not just the specific work that we're doing. So on the Harvard website, where the team birth page is, there's a statement saying the majority of C-sections are probably avoidable, or that C-sections, many of them aren't medically necessary. Can you extrapolate on that and help us understand what are some of the most common reasons that care providers cite to perform these C-sections, and how can we look at them a little bit differently?
Well, let me start here. We talk about how C-sections are the most common surgery that's performed. It's also true that the decision to do a C-section is the most common surgical error in the world and the most consequential error, for a whole bunch of reasons. It turns out that obstetricians like me are the only surgeons that cut on the same scar more than once. Like if a trauma surgeon has to go back and operate in a place they operated before, that's a bad day in their work week. But for me, that is every day, because most mothers have more than one baby, and it is very common to do a repeat C-section. And it turns out the first time you do a C-section, it's a very straightforward surgery. The second time, it's a little more complicated. And the third time, not to be too graphic, but it can be like operating on a melted box of crayons. And people can get very hurt. These are very complicated surgeries. In fact, sometimes the placenta, which is a big bag of blood vessels that gets 25% of everything that the heart is pumping, can get caught up in that scar tissue. And it's a condition called placenta accreta, but it can be deadly because when that happens, people very quickly bleed to death. And what that really indicates is a important truth that often gets forgotten, which is that people can get hurt in two ways in healthcare. They can get hurt when we do too little too late, which is what we're usually paying attention to, but people can also get hurt when we do too much too soon. So I just want to point that out, that the consequences of the surgery are significant. Now, from the last generation to the current one, there are a lot of things about the way mothers look that have changed, that are often an excuse that people use to blame mothers for the fact that C-sections are more common. So, moms are older than they used to be. There's more obesity, there's more hypertension, there's more diabetes, there's more IVF, more in vitro fertilization, which means there's more twins. And it turns out none of that explains the increases in C-sections that we've seen. And the reason is that if you are a healthy 18-year-old today, if you live in the US, your chances of getting a C-section have nearly doubled just over the course of your lifetime. So we cannot blame women, we cannot blame mothers for the fact that C-sections rates have gone up. Sometimes people say, well, moms are demanding C-sections. And it turns out less than 0.5% of mothers request an elective C-section with no indication. So that's just not true. It's not true in the US, it's not true in Australia, it's not true even in Brazil. There's also a narrative that, well, payment systems or medical malpractice systems are what's driving it, and the data does not bear that out. You can look at places that have very different reimbursement policies and very different medical malpractice policies, and they do not explain the differences in C-section rates that we see. So none of that is true. So then that begs the question, why are C-section rates going up? Why are they so different from place to place? And it turns out that the C-section rate at the hospital level is really measuring the quality of labor management. And the quality of labor management is directly related to how supported people are during labor. Fundamentally, the failure is over time, we have come to invest less and less in supporting people during labor. Doing the C-section is always the easier thing to do. The harder thing to do is to provide people with that support.
So strong. Again, all of those statistics, including just having 0.5% of people requesting elective C-sections. I wasn't aware that that was the number. I thought it was a bit higher. That's first of all, that's wonderful news. But second, it does make us think really strongly about what is going on inside there. And I wonder, one of the things that's come up as you were speaking is that there is the perception of people about the dangers of childbirth seem to be getting worse and worse. And I imagine that's, if you could look at a graph at how that's changed over the last few years, it might correlate with the increasing intervention rates. So we're using more intervention, and therefore the stories are that, oh my God, thank God I was in hospital and I almost died. But we're not talking about why you almost died. Maybe that was because you've had now 3 C-sections or 2, and you had to have the third one because you had a second one. You had to have the second one because you had the first one. So we're not backing up and looking at all the reasons that women are having more dangerous birth experiences. And I'm wondering what can be done about the perception in terms of not just the care providers, but the community as well. Yeah, I guess, is there part of your project that works on informing the people that are accessing the healthcare as well? So to help them understand a little bit better and for their perceptions to change around childbirth? Because even though they may not be requesting a C-section, but they might be agreeing to it very quickly because they believe that, that now they have the belief that childbirth is incredibly dangerous.
Well, I think that all people who are pregnant and giving birth are in a vulnerable position. And so we should do everything that we can to empower them. But we should also not place the burden on them entirely. Like everybody else has a lot of work to do interpersonally, and also to make sure we have a better system. So just want to be clear about that. That being said, I mentioned that it is less common for mothers to advocate for their own well-being. We started an organization called March for Moms. You find it at marchformoms.org, and it's on social media. And the idea of that is to provide a space to organize mothers and to try to drive public policy and practice. We also launched a project called Expecting More, and that can be found at expectingmore.org. And that's really about just expecting more, like that surviving is not the goal, thriving is the goal, and trying to basically use personal narratives of people's experiences to generate empathy for people giving birth and raise the bar on what people deserve.
You're tuned to Pregnancy, Birth, and Beyond.
We've talked a lot about the needs of birthing people, and it's important that we see care providers as human beings too. Clinicians across the world working on the front lines of healthcare, and especially doing the backbreaking work of supporting people during childbirth, were burnt out before the pandemic, and they're even more burned out now. And so I think that while we all collectively have work to do, we should recognize that every system is perfectly designed to get the results that it gets. And if our system is producing results that we don't like, the work is not just telling caregivers to work harder, to learn more, to be more aware, but making sure they have systems that they deserve that support them to do the right thing, to make sure that doing the right thing isn't always the harder thing.
I totally agree with that as well. And part of my work is sitting on many of committees at our local health districts, which are the government body that's responsible for providing healthcare, public healthcare here in Australia to the certain areas, because we have global healthcare here provided through Medicare. So every person in Australia has Medicare available to them. Part of the government that's responsible for providing that healthcare in different states, they're called different things, but there is such one in every single area. And I sit on those committees to help improve specifically maternity healthcare services through engagement with consumers, the people who are accessing the healthcare. And one of the things that focus on a lot is exactly this thing that you're saying, is not putting all the onus on the healthcare providers or the people accessing the healthcare, but actually providing a better system, and as much as possible, because the structure of the systems are quite difficult to change and it takes a long time, but it's worth it. The hours and years and time that people spend to slowly change the system eventually make a huge impact and difference for everyone involved. And I agree, the focus has to be also and specifically on changing structurally the system so that care providers can work better and the people accessing the care can have a better experience. Yeah, we're all people, we're all doing our best, and there's so many amazing people working in the system itself, trying to do their best with the circumstances that they have. Through the work that you're doing, are there specific aspects of it that are focused on structural changes within the system?
Yes, there are. Structural changes are things that require public policy, things that require investment in capacity, changes in regulation. But in the US, the focus, at least for this year, is making sure that we have this really odd system in the United States where if you're pregnant, you can access our public insurance system. But after you give birth, 2 months afterwards, your health insurance goes away. And 2 months after having a baby, for anybody who's a parent knows, that's when you're at peak sleep deprivation. It's just such a cruel thing to take away somebody's health insurance at that point. So the main objective of March for Moms this year is to make sure that people are at least covered through the first year after having a baby. And it's something that even in the current environment where American politics, people are so divided, there's broad support for doing that.
Yeah, that seems such an important aspect. That's really wonderful. And in terms of the structural changes for the system within the hospitals themselves to allow the care providers to be able to provide better care and make better decisions.
The way that we pay for care has to change in every way. It is true. Individual providers don't necessarily in our country make more money for doing a C-section, but hospitals do. And that doesn't make any sense because actually supporting people during labor is more expensive for the hospital. They have to dedicate staff time for that. Whereas, labor can take 20 hours, a C-section takes 30 minutes, and yet the C-section you get paid more. It makes absolutely no sense. We have to change the way we pay and reimburse healthcare services. We have to make sure that the right services can be reimbursed. So we're paying for, midwives without requiring physician supervision. We're paying for doulas. All of these things will make a really big difference. And I think all of those things are achievable.
Yeah, so changing the structural aspects of how things are paid. We're working on that here on our end in Australia as well, where at the moment the government pays per intervention, which is it's an incentive to do more interventions. And so we're trying to change that to pay per person accessing the care. And so there's a global amount of money per person accessing that care, and there's a cap for it as well. So they cannot just keep performing more and more interventions in order to receive, at the end of the day, more money. Or there's not the incentive, not that they're doing it that way, but that there's not the incentive to do that, because the bottom line suddenly looks very different. That's through the Medicare benefits scheme, which and some of it it's actually just concluded a 5-year review, and some of stuff has come through and worked and other stuff didn't. So it just goes to show the framework that's in place is very strong and very hard to change, but there is progress over time. Is there anything else that you want to impart to our listeners before we conclude? Such an incredible interview this morning and this evening for you, and I'm really thankful for your time.
No, it's my pleasure. Thank you so much for the conversation, and thank you for the work that you're doing for everybody who's listening and cares enough to be engaged. It's going to take all of us, and there's a lot of reason for hope that we can make things better.
Thank you so much, Dr. Shah. You've been listening to Pregnancy, Birth and Beyond with Dr. Neel Shah, Assistant Professor of Obstetrics, Gynaecology and Reproductive Biology at Harvard Medical School. Listed among the 40 smartest people in healthcare by Becker's Hospital Review and profiled by many major publications, he's written more than 50 peer-reviewed academic papers and contributed to 4 books, including senior author of Understanding Value-Based Healthcare. Dr. Shah is also the founder of Costs of Care, an NGO that curates insights from clinicians and patients to help delivery systems provide better care. In 2007, he co-founded the March for Mums Association, a coalition of more than 20 leading organizations to increase public and private investment in the well-being of mothers in the US. Dr. Shah currently serves on national advisory boards of the Planned Parenthood Federation of America and the Office of Women's Health Research at the National Institute of Health. For further information about Dr. Shah's work, check the show note links or head to our website, pbbmedia.org.
We hope you've enjoyed this episode of Pregnancy, Birth and Beyond. Tune in next week for more information and inspiration, bringing us full circle. You can find our show on iTunes, Spreaker, the usual social media under Pregnancy, Birth and Beyond, and our website at pbbmedia.org.